Hi, good to see you again, my dear friends from Kazakhstan. It's always lovely to meet you. My name is Serhat Bor. I'm a professor in medicine and gastroenterology, and unfortunately the chairman of the department in Ege University section or division of gastroenterology, Izmir, Turkey. As you know, we are running some monthly seminars with Nobel. I appreciate the Nobel for their kind support. So far, we organize many seminars every last Thursday. Every month, last Thursday, we are meeting. Come in, join us. So far, we performed 7 of those, or started with reflux, 4 of them. Afterwards, we move to the functional bowel disorders, and we finish a general one, irritable bowel symptom, constipation. Today, we have a diarrhea. Good news is I discussed the situation with Nobel, and the next one, I really wanted to talk with you regarding the functional abdominal bloating and distension, which is a pretty difficult situation, the nightmare of the whole functional GI disorders. And I believe it's going to be a very interesting talk because, finally I could talk about it, functional abdominal bloating and distension, and you will like it as well. I'm looking forward to meet with you next time, 22nd of October for the functional abdominal bloating and distension. But today we are going to talk about the chronic diarrhea, mainly functional chronic diarrhea and IBS diarrhea subtypes. When we look at the diarrhea, I'm not going to go all over this very difficult scheme, just to show you, how difficult the differential diagnosis of chronic diarrhea, how it starts, what is the epidemiologic factors, stool characteristic, is there any fecal incontinence? Pretty important. Pain, weight loss, aggravated factors. I have a medical student, I still remember, he came and said, "Hey, professor, I have a chronic diarrhea." After about 15 minutes of talk, he confessed that he drinks Coca-Cola 1 to 2 liters every day. 1 to 2 liters every day. Can you imagine? And I told him, "Oh, come on, this is fructose intolerance. Stop it." I came back, he said, "Everything is lovely. I am so good." Okay, no problem. He came back a couple of months later and said, I have chronic diarrhea." Okay, are you drinking Coca-Cola? He said, no way. But I am drinking orange juice every day, 2 liters. I'm supposed to kiss him or beat him up. Then this is what's happening. And this is why we are supposed to ask too many things. Systemic diseases, physical examination is also crucial. When we come to the routine lab test for any functional, any chronic diarrhea, we need some tests, we need some stool analysis, and then we are supposed to categorize them. Here, what we are saying that this is general functional, this is general chronic diarrhea. But since you are the experts, you know how to differentiate them from the functional diarrhea or IBS diarrhea. I keep showing this slide and I find it very much useful. Now, there used to be one big umbrella term named irritable bowel syndrome. We don't have it anymore. The main umbrella is functional gastrointestinal disorders, or the disorders of brain gut axis. You can go any of those, whatever. We always ask the predominant symptom. If predominant symptom is abdominal pain, then this is IBS. Then we ask about the diarrhea, constipation, or others. However, if there is no pain, but the predominant major symptom is constipation, we call it functional constipation, which we discussed during the last month talk. Or our patient comes with a predominantly diarrhea, if we don't have any organic problem, then we call it functional diarrhea. The most difficult aspect of all functional GI disorders is abdomen bloating and distension. If none of them exists, patient just come with the abdomen bloating and distension. In that case, we are supposed to talk about functional abdominal bloating and distension, which is going to be our next talk on the 26th of next month. Okay. I'm going to talk mainly regarding the functional bowel disorders with diarrhea guideline by United European Gastroenterology and European Society of Neurogastroenterology and Motility. It's an honor to be a part of this guideline. And I'm also a steering committee member of European Society of Neurogastroenterology and Motility. Okay, in that case, what are the points? Let's look at the differences between IBS diarrhea and functional diarrhea. We should separate them in order to talk about a better management plan, okay? This is crucial. Otherwise, we cannot say that those are different prototypes, phenotypes, because the problem here is if we are talking about IBS-D, we are talking about abdominal pain, okay? But for functional diarrhea, there is no pain but diarrhea. And that should be at least within the last 6 months. Prior to diagnose, the symptoms should exist for the last 6 months and criteria fulfilled for the last 3 months. This is the important one for the definition, because for this part, for IBS, I also use spasmolytic agents, but functional diarrhea, it's pretty much debatable. How about the psychological factors? Very recent paper is coming, Rome 4 group, publishing the major psychiatric comorbidities in patients with functional GI disorders. Very amazingly, for example, in Turkey and Egypt, we have the highest level of psychiatric comorbidity. For Egypt, 60%. For Turkey, 57% of patients with functional GI disorders have psychiatric comorbidity. And we know that all our patients actually have interestingly, main anxiety. Also, but depression is more common in IBS-D. We should know that. Then what is the conclusion? Chronic diarrhea was strongly associated with depression. Then we can easily say that there is a relationship between mood and the specific bowel habits. What we are learning from this particular topic is functional GI disorders are not psychiatric diseases. However, those patients who come to us, who come to see the doctors, have higher level of psychiatric comorbidity. This is the crucial point, psychiatric comorbidity. Okay, and this is a slide regarding this. If we have a patient at home, and if the patient not going to the doctor, psychological disturbances echo to the people at home without GI disorders. However, if patient comes to the doctor, psychological disturbances are much more prevalent than the IBS patients stay at home and healthy volunteers. That means this is not a psychiatric disease, but psychiatric comorbidities actually worsen the functional GI symptoms, and we are supposed to deal with both problems, functional problem, GI problem, as well as psychiatric disturbance problem. And also, fecal incontinence. It is pretty common. It's a big problem. There is a nice sentences regarding that. Don't ask, don't tell. If you don't ask them, they never tell you. We are supposed to ask the patients, do you have any incontinence? Okay, it's a big problem. We perform a study in Turkey, about 3.5% of the whole generation. 15% of the patients older than 65 years old actually define stool incontinence. This is a pretty difficult situation and no one cares. By the way, I'm expecting your question, okay? Please send me the questions and I would love to answer your questions either during my talk or at the end of my talk. They are going to send me the questions using the WhatsApp. You see it's pretty, fecal incontinence is pretty common in those patients. How about the testing? Should we test all of them? This is an important point because too many underlying causes. In that case, which test we should perform? CRP is pretty important. Erythrocyte sedimentation rate, actually no. If our patients resistant to the initial therapy, which we will discuss, we can test them for celiac disease with tissue transglutaminase or immunoglobulin A. Okay, and should we biopsy all of them? Not yet, but this is something else. Routine thyroid test not required, patients, but if you have a clinical suspicion, go ahead and test for the thyroid. Fecal calprotectin. This is a pretty important test. However, we have some difficulties with normal values of fecal calprotectin. What I believe, if I have a patient with normal fecal calprotectin, if I have a patient with normal CRP, then possibility of, normal means less than 50, by the way, possibility of having IBD is so low. I can practically nearly exclude the patients, especially if you have difficulties to reach your patients for the colonoscopy. It's a nice way of doing, okay? This is a study showing that CRP is less than 0.5. In this one, calprotectin is less than 40. IBD possibility is less than 1%. If you have no opportunity or if you're very busy, colonoscopy clinic, difficult to find an appointment, just test them for that. Celiac disease, unfortunately, many studies performed during the IBS years. That means before the Rome 4 study. In that case, we don't have specific studies defined by functional diarrhea, but we know that in patients with IBS, celiac prevalence is about 4.3 times higher. Do I check them? As I mentioned, UEG, this guideline doesn't support it, but I'm checking. I will come back this one later on. Routine stool testing for enteric pathogens. Yeah, you can do that, but that's the Western guideline. I hate those. They say that if your patient travel to developing countries, test it. Guys, we are the main, some parts of Turkey is actually still developing countries. And also, I believe some part of Kazakhstan the same. We can check them. But I see very rarely parasites or ovals in patients specific for giardiasis. But remember, if you have a patient with selective immunoglobulin A insufficiency, then you should check for giardiasis because there's a high risk of in those patients group. Colonoscopy, I keep showing this slides from the beginning because this is the only study about that. A colonoscopy nearly not useful. We don't perform it if you first come, oh, welcome, let's go to the colonoscopy. We don't do that. But because there is no such a big difference between IBS patients and controls in non-constipated ones. In constipated ones, if there is no alarm symptom, there is no indication. For non-constipated one, if you perform a colonoscopy, then it is advisable to take the biopsies in order to differentiate collagenous colitis, lymphocytic colitis, or others. Okay, this is important in these patients. There is a meta-analysis showing that microscopic colitis is about 10% in IBS-D patients, and specifically in women patients and about 60 years old. However, it's possible to see them in younger age. However, our problem is you need a really good pathologist with a deeper knowledge of identify the pathology. And please tell your colonoscopist to take the biopsies from right colon and left colon for the differential diagnosis. If there is a colonoscopy in a patient with chronic diarrhea, always biopsies must be taken. This is it. Okay, let's make an agreement. We got that. Still waiting the question. Only Shirin is asking the question. No one asked. Too bad. And she asked only one. I don't know how common to use video capsule endoscopy. We can use it in Turkey in some cases. It is expensive though. If we have a suspicion of really severe disorder or very aggravating symptoms, or patient refractory to the regular therapies, there is a possibility you can use video capsule endoscopy or enteroscopy. Generally, what is advisable is perform this small bowel imaging, such as MR enterography or video capsule endoscopy. If you detect a lesion, then it's possible to specifically perform enteroscopy, double balloon or single balloon, whatever. In chronic diarrhea patients, if you can do that, video capsule endoscopy is an option. SIBO test. Oh, this is a meta-analysis and systemic review for this small intestinal bacterial overgrowth in patients with IBS. As I mentioned, IBS used to use to cover the term of all types of functional GI disorders. There is a link. Let's make an agreement. Okay, I have no objection that there is a link. However, the problem is there is no clear-cut diagnostic methodology for SIBO. Breath tests still have some weaknesses. Aspiration using the endoscope is pretty difficult. Then what we do, if we have a clinical suspicion, specifically if there's an underlying cause in the patient, then we can treat them with some non-absorbable antibiotics or maybe probiotics. We'll come back later on. And this is why our group actually voted against routine diagnostic tests. If there is a GI motility disorders, anatomical abnormalities, hypochlorhydria, immune deficiency, malabsorption, yes. Otherwise, no. And no routine use of breath tests, no routine use of microbiota testing. In Turkey, there is a big abuse regarding this. Okay, and we are fighting for that, saying that don't refer your patients for those tests. Please don't do it as well in your lovely country. Okay, let's start the therapeutic approach. I loved, oh, this restaurant was lovely. You know, I eat nothing, just a small piece of lunch because Nobel is run out of money. They just buy me this very small dish. And you see, I'm suffering. Look at my face, a suffering guy face. Yeah. Oh. Just give me a second. It was lovely food. Let's start with the diet. First of all, in regard to the microbiota, all the diets are not good for our microbiota except Mediterranean diet. I love this figure. It shows that all the vegan, vegetarian, gluten-free, ketogenic, or FODMAP or Western diet, they all decrease the microbiota diversity, total microbiota abundance. This is a problem. None of the diet is healthy. I'm not saying that if you have a patient with celiac disease, don't use gluten-free diet, never. The patient must be on gluten-free diet. What I'm saying is there are some new fashions. Oh, let me get some gluten-free diet. It's very healthy. This is not correct. And also gluten-free diet is also support to gain weight. This is why we don't like it. And others as well. Stick with Mediterranean diet. What I do in my practice for the diet, when I have a patient with IBS or chronic diarrhea at the same point here, what I do is I tell the patients, I discuss with my GI-specific dietitian, and I tell my patients, go ahead and get a diary and check all the medications. I'm sorry, all the diet factors. I'm also checking the questions. Please ask me more questions. Someone asked about the type of Mediterranean diet. It's generally based on vegetables, olive oil, olive trees, and other healthy, fresh salad or others. This is mainly the base of Mediterranean diet. And for the IBS patients, I check for eating behavior also. Some of them really having, as my medical student, how things are going, lifestyle, and also the allergies, food, and I ask specific food, guys. What are the specific food producing more diarrhea? And then I ask also fatty food. We should remember pancreatic exocrine insufficiency. In that case, we should some enzyme preparations. A high level of caffeine. Caffeine is a lovely laxative, and others, alcohol, severe alcohol, chronic pancreatitis, whatever. If I can identify the type of diet, then what I do, I exclude those specific diet factors from the diet and work with my dietitian. This is what I do in general. If patient doesn't respond that, then between those two here, I try a gluten-free diet, even though our guidelines don't suggest that. Because there is a subgroup of patients with the non-celiac gluten sensitivity. I've just seen a pharmacist. Today, I perform an endoscopy in order to take the biopsies. All of his tests were negative. Her endoscopy was normal, even though we took the biopsies. But he's saying that, Doc, if I'm on gluten-free diet, my urticaria improve, my psychiatric conditions improve, my bowel improve, everything improve in my life. I feel so good. And I tried a couple of times. This is why I'm so happy with it. In that case, this is as patient with possibly gluten-sensitive, non-celiac patient. If they don't respond, then I go to low FODMAP diet. Low FODMAP diet is a difficult one, if I tell the truth. Okay, it's a pretty difficult one. We continue 4 to 6 weeks only in those cases. As I said, our group against the gluten-free diet. However, funny, there are 2 randomized control studies. Both studies show an improvement. They say, okay, this is a good one. But for the meta-analysis, when 2 trials were put together, then the results turned to the insignificance. This is why we couldn't suggest it, but I use it in my practice. For FODMAP, fermentable oligosaccharides, disaccharides, monosaccharides, and polyol, there are 3 lovely meta-analyses published within 1 year nearly. They all show beneficial results. And this is why for IBSD, there are studies showing short-term usefulness. No evidence for functional diarrhea, but it doesn't mean that we should not use it. Even if I have a patient in my practice with functional diarrhea, if they don't respond to the regular dietetic restrictions, the gluten-free diet, then I try FODMAP, okay? Let's make it clear. Okay, let's go to a couple of questions. Hi Shrin, good to see you. How are you? How to differentiate intestinal tuberculosis from functional diarrhea? Oh, but this is totally organic disorder. Is there anything in the lungs? No. Then we check some tests, as you know, blood tests or others. Number 2, we go with the MR enterography, colonoscopy, carefully checking the terminal ileum, and MR enterography is also helpful. And also you can do some video capsule endoscopy and others. Okay, it's a total different thing. Yes, we should exclude them for sure. If you have a suspicion, it's nearly not exist in Turkey, a couple of cases per year. Alimbetova Ulbala, Bolatovna, okay. The patient had dolicho sigma, fecal calprotectin is 149. What's your treatment tactics? Do you alpha normix? What is alpha normix? Is it rifaximin? I have no idea. Send me the what does that mean? Okay. And there is another question, but still I am not sure. Can empiric cholesterol be prescribed? Urimbaev, are we asking the cholestyramine, not cholesterol? Is it possible? Please send me the question again and I will respond it. Now let's come to the spasmolytic agents. Who need that? First of all IBS patients need spasmolytic agents. Unfortunately, since there is no spasmolytic agents in the United States of America except Buscopan, none of the guidelines from USA talk about it, mention it. But we know that there are two good spasmolytic agents which unfortunately they don't exist in Kazakhstan, pinavarium and otiloyum. And in many other countries, you have mebeverine or trimebutine, and some of them has alverine. First of all, stay away from hyoscine, okay? Try not to use Buscopan because of side effects and drug interactions. This is a meta-analysis written by myself and Jan Tak. We look at the we perform a meta-analysis, look at the effect of pinavarium. It is pretty much effective seen here, and specifically in stool this is a study may look at the secondary endpoints. Stool consistency improved, stool frequency improved means good for the diarrhea, and others also improved with pain. That means in the zinc study, they show that pinavarium is useful for the patient with functional or IBS-related diarrhea, even by itself. Okay, this is important. Otiloyum is also useful. However, the effect starts a little bit late in those cases. And also our guideline suggests in patients with IBS-D, but there is no data for functional diarrhea. Should I try it? Sometimes yes, because it's easy to access for those medications. You can try for the functional diarrhea. I have no object against that. Before, okay, loperamide. Actually, I love loperamide. It's a good medication. In some randomized control studies, it improved abdominal pain. They are saying that no efficacy improvement global IBS-D symptoms. Come on, I use it, okay? Because it is nearly unnoxious medication, innocent medication, and I use loperamide up to 6 tablets a day without any hesitation. This is a question with rifaximin. I have just learned that alpha normix is a rifaximin. Okay, we are doing some advertisement. Now, can I use this medication in a patient with dolicho sigma fecal calprotectin? What is your treatment tactics? Where I use rifaximin? I use it for abdominal bloating and distension, not for the first medication. Diet, afterwards spasmodic agents, then the rifaximin. But number of needed to treat is 10. That means in order to treat 1 patient, we are supposed to give the medication to 10 patients. Remember, let me go back. For the pinavarium, it's 3.8. Okay, 3.8 versus 10. As you see, pinavarium is a much better choice, but you can try rifaximin up to 1,000 milligram, which is useful one, at least 14 days. You can use it, and if your patient respond to the first therapy, you can use for the second and third one. This is a study, but remember, for the fourth treatment, first group, first time, second time, third time, fourth time, and that we have only 6 or 4 patients, a small group, but third prescription might work. What I do in my practice, I prescribe the rifaximin. If they respond from the first one, then when their symptoms recur, I reinitiate the rifaximin. But for your practice, for your patient, dolichosigma, how do you recognize it? There is no relationship between the length of the colon and the symptoms. There is no study showing that. Also, fecal calprotectin is somewhere around the middle, not totally normal, not totally pathologic. It depends the patient's symptoms. You didn't write anything about the symptoms. If this is a chronic diarrhea, I will suggest you to go ahead and perform a colonoscopy since the calprotectin is middle, okay? And tell the colonoscopist, take the biopsies. Otherwise, just treat them. You can use rifaximin if you wish so. Let me move to the probiotics. In terms of probiotics, this is a very tricky subject. I'm not saying that intestinal microbiota is not important. I think it's very important. I have no problem with that. I have a huge respect to all type of microbiota studies. However, the problem is there is no single probiotic. There are too many different probiotics. In that case, you see here, some probiotics work for some patients, others work for other patients. You can look at this figure and you can choose your probiotic. Number of needed to treat is 7. And it's not clear which species is the most beneficial. This is why, although probiotics may improve diarrhea in IBSD, not specifically tested in functional diarrhea. Do I use it? Yes. When? End of my therapeutic list. Diet, spasmodic agents, rifaximin, and afterwards, maybe probiotics, which there is something much more important than that. And this is the probiotics. I have already mentioned that. Okay, this is pretty important, very important, because we know that about 28% of patients with IBS diarrhea have bile acid diarrhea, and no one knows about that, my friend. No one knows it. There are 3 types of diarrhea, bile acid diarrhea. Type 1 is ileal disease, resection, Crohn, whatever, something else, very specific group. Type 3, cholecystectomized or celiac patients. Some people knows that because cholecystectomy patients is easy. If you have a patient with cholecystectomy with functional diarrhea, okay, this is bile acid diarrhea. Life is easy. However, there is a group called idiopathic or primary. You see it. This is all genetic because the feedback from the intestine to the liver in order to synthesize the bile acids is defective. We have a problem here. And also we know that some is also useful for bile acids, also inhibitors useful for the therapeutic approach to constipation. But remember, those patients are specifically defined as severe diarrhea after the breakfast. If they eat a huge Turkish style of breakfast, they immediately run to the defecation, to the toilet. Okay, and this is very watery diarrhea. And diagnosis tests are pretty difficult because C4 or FGS19 measurements nearly not possible. There is a scintigraphy called CCAT. It is rarely available, not available in Turkey. In this case, what we do, and we just put them on cholestyramine or cholesevelam, whatever you have it, and see whether they're going to get better or not better. This is our diagnostic test. As I mentioned, see how prevalent the bile acid malabsorption in patients with IBSD. Now you are asking questions. Thank you for that. The role of sorbents and combinations with antispasmodic, Bibigül is asking from Astana. I love Astana. Oh, I think with the mentioning of sorbent, are you talking about simeticone? If yes, simeticone is useless, number one. And the combination of simeticone with other molecules such as alverin or pinaverium, whatever, simeticone decrease the absorption of this active molecule. This is why there is no scientific evidence regarding the positive effect of medications combination with spasmolytic agent plus simeticone. Okay, if antispasmodics are ineffective, what should be added? Do you use sulpirit for IBS? First, I use amitriptyline, 10 milligrams, starting from 10 and go up to 20, up to 75, but 75 is too high. Higher than 20, mainly antidepressive, but less than 20 is generally, we call it neuromodulator. Okay, Shamsalieva, Kunsulu. Generally, I use, and specifically for diarrhea patients, which I'm going to come this one. I think it's somewhere, I'll come back later on, but I use it. Rifaximin and probiotics treatment, Shirin. Rifaximin 10 to 14 days. Probiotics, I mean, you can use for 1 to 3 months with probiotics, okay? Not a big deal. And how about as you see here, our guideline also recommend cholestyramine. If you have cholesevalam, but as far as I know, you do not have cholesevalam. They say we don't have it either. Cholesevalam has less side effects. Is there any role of fecal microbiota transplantation in IBS? No, in IBS, but we'll talk about it in next talk regarding the functional bowel, functional abdominal bloating and distension. We are currently against the fecal microbiota transplantation in patients with IBS or functional diarrhea. There are other medications such as elyxadolin. We recommend to use it if you have it, Vibarzi, or allosetron, possible to use it, but rarely we need it, if I tell the truth. They are mainly effective for the stool frequency, sometimes with the pain, okay? Either allosetron or elyxadolin, if you have it, you may try for it. I've already mentioned neuromodulators. Amitriptyline is a lovely option for that. If your patient does not respond to amitriptyline, you can use the sulpirit. I have no objection for that, Dr. Kunsulu. Okay, and this is, but remember, our guideline against use of SSRI for treating diarrhea, because there is, unfortunately, in patients with diarrhea, there is no enough scientific evidence in order to use it. TCA, yes, but we need more studies, but I use it a lot. Be careful with the side effect of TCA, tricyclic antidepressants or neuromodulators, we call it. Please be careful with the side effects. We finish this one, but let me see if there are any more questions. Isolated increase in transaminase without liver damage, not responding to therapy with GCS, Heptral, Ursosan. What disease should be excluded? I'm not sure about this question. Please clarify it, Dr. Tulagonovna. I need too many more details in these patients. Cholecystectomy and prolonged diarrhea, always have increased biopsy stool analysis. Yeah, if you can check for stool for the bile acids, you can find, but studies show that they are not specific. The bile acid detection in stool is pretty difficult. You can use it, but why don't you try it, cholestyramine at the beginning? Sorbent, still you are asking about sorbent. Are you talking about the simeticone? Please clarify it. Is it possible to prescribe probiotics with rifaximin? No, because if there's a bacterial type of probiotic, rifaximin might also kill the beneficial bacteria in the probiotic agent. This is why we do not suggest to combine together. And also, you never know which one is effective. Try one by one. Okay? Let's summarize with what we say so far in those patients. Okay, IBS-DM function, there are possibly two, but potential overlapping, two separate but potential overlapping disease. Please come back them with the symptom-based approach. You don't need exclusion type of, you don't need to exclude all the other disease, just perform minimal diagnostic testing, okay? Always ask for psychosocial factors, always. And always ask them for fecal incontinence. It is a nightmare for having fecal incontinence in those patients. Limited blood testing, just look for CRP, just perform the fecal calprotectin, and if you have a refractory patients, try serologic testing to rule out celiac disease. And also, this our
И
consent.
также мы достигли консенсуса о том, что не надо рутинно всем подряд назначать тестирование кала, ну и некоторые другие тесты. Я еще буду к этому возвращаться. Колоноскопию можно проводить, если есть показания. Если проводите колоноскопию, пожалуйста, обязательно возьмите дистальный проксимальных отделов биопсию. Видеокапсульная эндоскопия нужна только если у вас есть подозрения конкретные, допустим, вот как туберкулез кишечника, да, можно провести, ну, там с обструкцией надо быть осторожным. Энтероскопию можно проводить, если вы обнаруживаете какие-то очаги поражения, и вам требуется дополнительный эндоскопический диагноз, где биопсия, если терапевтические вмешательства нужны, то можно. А в остальных случаях мы, например, не рекомендуем использовать дыхательные пробы. По малябсорбции желчных кислот, ну, можно попробовать тест провести, но если нет у вас диагностических тестов для этого, то тогда просто используйте колестромин или колесовилам. Если говорить об избыточный бактериальный рост, у всех подряд это не надо проверять, за исключением пациентов с основными заболеваниями, о которых я уже говорил. Микробиоту мы не тестируем, потому что это просто трата времени и денег. Можно назначать спазмолитики, особенно для пациентов с СРК с диареей. Ну и, в принципе, даже при функциональной диарее можно назначать у некоторых пациентов спазмолитики. Но, к сожалению, жаль, что у вас недоступен атилоний или пеновериум. Вы можете тримибутин использовать или мибиверин в таком случае. По мибиверину некоторые исследования показывают, что он на качество жизни может повлиять. По лапирамиду я рекомендую, настоятельно рекомендую лапирамиду использовать. Рифоксимин, да, можно применять, но эффекты будут ограничены. Я вам, помните, говорил, что ЧБНЛ 10. Можно для СРК по типу диареи и для некоторых пациентов с функциональной диареей применять. Если пациент реагирует на препарат, то продолжайте, если нет, то остановите. Рифоксимин, кстати, при запорах использовать не надо. Пробиотики, да, можно использовать для СРК по типу D, то есть по типу диареи. Для запора, мне кажется, нет. Также у нас есть отдельное руководство по запору, там мы не рекомендуем использовать пробиотики. И также мезолазин никак не влияет. Вот по FODMAP-диете, если ничего не работает, если ничего не помогает, уже попробуйте низкие FODMAP-диеты. Можно психологическую терапию, в принципе, проводить. Ну, насчет акупунктуры и других альтернативных методов лечения не уверен, но на каких-то отдельных пациентах можно попробовать. И эликсодалин, в принципе, да. Трициклические антидепрессанты, да, можно. Селективные ингибиторы обратного захвата серотонина нет. И антагонисты 5-HT3, ну, говорят, можно использовать, но я лично не имею опыта применения. Давайте поговорим о подходе к диагностике. Есть некоторые исследования. Бибигуль задает вопрос, да, по пробиотикам. Пробиотики на раннем периоде ухудшают ли симптомы? Мне кажется, не должны. Нет. Если у пациента после введения пробиотиков ухудшается состояние, если функциональные симптомы ухудшаются, надо перепроверить, знаете, наверное, психиатрические сопутствующие заболевания, я бы так сказал. Нужно ли уровни витаминов измерять? В принципе, нет связи между уровнем витаминов или дефицитом витаминов и функциональной хронической диареей. Ну, смотрите на свое клиническое усмотрение. Если какие-то у вас подозрения есть, можете проверить уровни витаминов, если нужно. Что назначить при недержании кала? Доктор Земфира спрашивает. Знаете, это целая большая история. Если мы продолжим работу с Нобель в 2024 году, настаивайте на этом, то мы тогда, может быть, сможем целый вебинар посвятить как раз теме недержания кала, потому что это вообще совершенно другой аспект, отдельная тема. Давайте поговорим о подходах к диагностике. Если у вас пациенты с хронической диареей, если симптомы не очень тяжелые, используйте просто симптоматический подход. Лапирамид можно назначить. Если это долгосрочная проблема, проверьте особенности диеты, попробуйте, может быть, секвестранты желчных кислот. Если есть тревожные симптомы, тогда надо, конечно, все исследования провести. Я тут даже не буду говорить, вы все прекрасно знаете, что делать с тревожными симптомами. Если аномалий нет, то нам нужны только... Если при ограниченных тестах нет аномалий, то попробуйте фенотип определить. Это функциональная диарея или это у вас диарея, связанная с СРК? Легко это сделать. Если у вас боль есть, то это СРК. Если боли нет, то это функциональная диарея. Сильно ли это влияет на лечение? Ну, иногда может повлиять. Допустим, если у вас пациенты с СРК, то там важнее назначить спазмолитики, потому что вам надо с болью работать, нужно боль убирать. Попробуйте спазмолитики, если не реагируют, то трициклические антидепрессанты. Вот Наталья спрашивает, на какой срок назначать? Можно на 3 месяца, как минимум, до 6 месяцев можно назначать трициклические антидепрессанты. От 3 до 6 месяцев. И к этому еще нужно добавлять в некоторых случаях противодиарейные препараты. Холестерамин, может быть, лапирамид, может быть, диета и так далее. Если не реагируют пациенты, тогда попробуйте уже дополнительные диагностические тесты провести. Ну и я так думаю, что вы проводите анализы кала на кишечные инфекции. Это еще один момент. Какие могут быть причины боли в правых отделах подвздошной кишки? Связано ли это с холелитиазом? Ну, мне кажется, наверное, нет. Надо проверять. Если это хроническое заболевание, то посмотрите, возможно, это функциональное расстройство кишечника. Это может быть две основных причины. Либо болезнь Вечета, либо это может быть проблемы терминальных отделов подвздошной кишки. Если это женщина-пациент, проверьте еще на гинекологические проблемы. На самом деле очень много может быть причин. Я думаю, что проблемы не в холелитиазе. Ну вот, друзья, на этом, в принципе, моя презентация закончилась. 47 минут всего. Я молодец. Я всегда говорю о том, что важно начинать и заканчивать вовремя. Ну так вот, я напоминаю, да, что мы поговорили о функциональной диарее. И напоминаю о том, что мы собираемся в каждый последний четверг месяца. Сегодня мы обсудили функциональную диарею. Буквально до начала вебинара мы с Нобелем договорились. И еще раз хочу поблагодарить компанию Нобель за то, что она организует наши с вами встречи. Так вот, мы договорились, что наша следующая встреча будет посвящена очень серьезной проблеме, это функциональному вздутию и напряжению. Очень интересная тема будет. Давайте вам сразу скажу, что у таких пациентов, представляете, не увеличивается формирование газов в основном только у 25% пациентов с функциональным вздутием. Потому что обычно спроси у а, пациентов, почему возникает вздутие, и все говорят, что это, наверное, происходит только из-за формирования газов. Но это не всегда так. Ну, я напоминаю, что мы все эти вопросы исследуем в нашем департаменте гастроэнтерологии, и благодаря компании Нобель мы можем поделиться этими знаниями с другими врачами. Вот даже к нам в департамент привозили уже, по-моему, 50 врачей. Замечательная встреча была у нас. Мы на таких встречах проводим, как проводить пищеводные, аноректальные тесты, как импеданс-катетеры устанавливать, как проверять ам, мотильность, ну и многие другие. Ну и на этом я, наверное, сегодняшний свой вебинар закончу. Спасибо всем.